Okay, welcome to our lecture on schizophrenia spectrum and other psychotic disorders. Schizophrenia is a condition that many of us you will work with in our field placements. Certainly, if you work in inpatient settings, you'll often see folks with individuals with that diagnosis. One of the things about schizophrenia that for me is tragic about it, in some ways uniquely tragic in some ways to others, is that many times what we see are people who are no necessarily, now some have health histories and other comorbid health issues, but many people have no health history whatsoever, and are functioning very well, and suddenly in their late teens, early mid late 20s, often when it occurs, the symptoms come on relatively suddenly, although they can be sort of steadily coming in and are getting worse over a period of time, and the person is you know unsure what they are, oftentimes scared and unwilling to even acknowledge to others that they're having these symptoms in the hopes they'll go away. And while we do have treatments for schizophrenia, and some people can function well and have a quality of life, for most people, there's not a return to the baseline they experienced before the onset of the illness. So in that way, it is somewhat uniquely tragic from other disorders in the DSM. And we see that in the video we're going to watch together over the you can watch it prior to this, but prior to starting this, you'll have a link to the entire video, where you can watch it kind of in a part one and part two throughout the slideshow here. And I'll explain what that means in the next slide. So hope you enjoy the lecture. Okay, so as I said, you'll have a link to this video in the readings and lectures folder, and you can watch the entire video through. This is from the National Health Service in West London. It's a fictional scenario. The individuals are portrayed by actors, but I think it does do a nice job of kind of illustrating what the initial onset, in this case, where onset has begun maybe weeks or a month or so prior, and how it sets in and what it looks like when it's for the first time noticeably, and it's noticeable to others, and the functioning becomes noticeably impaired. The individual's functioning becomes noticeably impaired. So in the first segment, you see our fictional client at home with his mother, and she calls emergency services, and they do an in-home triage. That's the first part, around the first 10 minutes, and then the second half is his evaluation in the emergency room. So, like I said, there are two ways to do it. You can watch the whole thing now, or watch the first 10 minutes of it, and then we're going to walk through some of the criteria that's illustrated well in this video, or well to me anyway, and then watch the ER evaluation as we move into some of the diagnostic features and other aspects of schizophrenia. So either way, your choice, and we'll get into the criteria. Okay, so the DSM authors took an approach that is, let's see if my pen's working, that is similar to what they did in the bipolar disorder section. And what they did was, if you recall, in bipolar, they said, okay, before we get into the diagnoses of bipolar 1 and 2, we want our clinicians and any reader of the DSM to clearly understand with criteria a hypomanic episode, a manic episode, and a major depressive episode in the context of bipolar. So, and then you plug those concepts into the diagnoses themselves. And so schizophrenia is done in a similar fashion because it is a very, and I think it is a sensible thing to do because it's a very complex illness with a wide range of symptoms. So what they've done, and the one thing I realize as I'm going through here is the limitation of VoiceThread is that I can't flip through slides to show you multiple slides at once. It only allows comments on one slide at a time. So, so 5 domains are delusions, which you see here, and the other 4 are hallucinations, disorganized thinking, disorganized thinking and motor behavior, and negative symptoms. So what we'll do, just like we did with bipolar, is we're going to walk through those 5 concepts, uh, and and then, just like the DSM does, then we'll go into how those phenomena fit into the diagnosis of schizophrenia. Okay, so the first one are delusions, and a definition you're likely familiar with: fixed beliefs that are not amenable to change in light of conflicting evidence. And there are a variety of themes, is what's the word the DSM uses. So you have persecutory, referential, and grandiose. So you can read the definitions there, and they can overlap too. So you don't necessarily have just one. You can have, people can experience any combination. Sometimes it's just one. So understanding that these can sort of appear to be blending together is just something to be aware of. But this at least gives you a sense of sort of a framework to understand delusions. Okay, and here we see a further breakdown of um, sort of a theme, again, using the DSM's words, a theme to a person's delusions. So we may see delusions where someone believes that they have a relationship with a person who doesn't, uh, who may not even be aware of them. Certainly, we occasionally hear about people who are in the public eye or celebrity of some sort, um, finding themselves, and not necessarily attacked, although that certainly happens sometimes, that that there's aggression towards that person. But it doesn't necessarily have to be aggression. In fact, probably most of the time it isn't. And, because we don't necessarily hear about those. We usually hear about the ones that are more dramatic. But the delusion is that they have a relationship. It doesn't necessarily mean that the person's in love with them, but certainly the delusion that they have a relationship that doesn't really exist. Okay, and you see the nihilistic delusion, the major catastrophe will occur, and somatic delusions, preoccupations with health and organ function, but illnesses that they don't have. Um, uh, One of the ones that can be very dangerous is that people feel like they have a tumor or some other, some foreign object, non-biological object within them, and that they need to get them out. And so, which gets us back to the one of the things that I think the video points out, which is um, I think we still struggle. Hopefully, it's less so today than when I was a student or years prior. That's people with schizophrenia are more likely to be violent perpetrators of violence, when in fact the data's pretty clear that they're actually more likely to be victims of violence, and that can be their own, victimization. And sadly, I've definitely seen people do significant harm to themselves because they believe that they have something in them or something wrong with them, and they need exercise it themselves, which can lead to crisis events, emergency or crisis events. And certainly people with nihilistic delusions can be often isolative, and certainly people that have those delusions can be very susceptible to a lot of the conspiracy content on the internet, and that can it can be a place for them to sort of they doesn't necessarily cause it, but can certainly fuel the delusion that might already be there. Likewise, the internet also can affect the erotomania delusions, because it's a little bit easier to tap into to public people's or celebrities' lives, and it's probably easier than it was prior to the internet, to create it, to sort of endorse the delusion that there's some kind of connection to them, because you can in some ways get closer to them, I suppose, through social media and other internet means. So there are aspects of the internet that may um, that may be more problematic now than prior to the internet. Certainly, I actually had a student in this class years ago um, mention that she was working in a community health center in her field, and they had a person with paranoid delusions, persecutory delusions. And I believe it was a history of schizophrenia, if I remember correctly, because I do recall it was the student mentioned the story during a lecture, and the individual had access to a social media account and was posting content about the president of the United States. I think it was Trump at that point, and lo and behold, the Secret Service showed up to the community health center to follow up with this individual who had been making this post, and um, that's something that wouldn't have happened when I was a student, is that people just wouldn't have the access to put the kind of delusional content out there. But whatever the person had put online actually did draw the attention of the Secret Service, and I'm sure that that's something that probably happens, and again, a consequence of the symptoms and the illness. Just ignore the hallucinations, disorganized thinking. I think I put those two in there in the air. We're going to get to them in just a minute here. So I believe the DSM puts in here is sort of a clarifying definition, that across, intercultures, if you will, or yeah, intercultures may deem things to be bizarre or delusional, simply because it's foreign to their, or perceived as that foreign to their own culture. So um, so the DSM authors expand the definition to include clearly implausible, um, and not understandable to same culture peers, and do not derive from ordinary life experiences. Um, so for instance, um, if you, I'm trying to think of an example in the U.S., but one that comes to mind is an example on outside the country in Syria, where young men are, at least over the past few years, I'm not sure how much this still goes on today, but a few years ago it was something that was significant, where young men were sort of rounded up and forcibly um, drafted, if you will, into the military, to serve in a form of some band of military, and so to live in fear of that, to be sort of preoccupied with it. And just thinking of a particular documentary that I watched on this topic a few years ago, um, That's part of ordinary life experiences. So to be consumed with fear that you are going to be, forcibly removed from your home or your community and put into military service, um, at least for a period of time in Syria, that was ordinary life experience for young men. And so to be consumed of that would be congruent with the circumstances. So just an example that pops into mind. Um, there's also a theme of delusion or delusions that involve loss of or control of mind or body, and uh, the DSM authors break that down further into thought withdrawal and thought insertion and delusions of control. And again, these can lead to behaviors that are self-destructive and sometimes even destructive because people are responding um, to what they believe is direct external control, um, and which can be constrained to thoughts, but also can be include the behavior, body movement. Um, that's another theme of delusion. Okay, so let's take a look at hallucinations. So what I did here was I took the breakdown of the definition of hallucinations from the DSM, and so some basic tenets of what a hallucination is, as defined by the DSM, in the context of domains of schizophrenia. So perception-like experiences that occur without an external stimulus, keeping in mind that these can be not just visual or audio, but they can be olfactory. They can be, related to taste. So any level of maybe auditory and visual are the most common, but certainly any one of our senses can be affected by hallucination, and they are generally vivid and clear, and have the full force and impact of normal perceptions. So it is seen or heard or smelled, um, or a sense of taste that is as real as anything you or I can experience. And it's in the context of schizophrenia and the five domains of schizophrenia. It's not under voluntary control, and exclusive to and non I'm sorry, so exclusive to a semi falling or weakening state. I think I meant to put not. Sorry, so that is not exclusive to a semi-waking or sleeping. In other words, what the authors say was, we all might be groggy, and maybe hear a noise, for instance, that may actually still be sort of an evaporate, slowly dissolving dream state that we were in as we're waking up. So they just specify that it's not that. So sorry, that is meant to be a not exclusive to semi or waking sleep state there. Okay, so for the purposes of our exam and just understanding, basic understanding of the five domains, this is, I think, the important part of hallucinations. And then we'll get into disorganized thinking, behavior, and negative symptoms next. Okay, so disorganized thinking, and I wrote it this way because this is how the authors wrote in DSM, is disorganized thinking is most commonly manifested through speech. Okay, and you see typically inferred through individual speech. So what does that look like? Switching from one topic to another, um, also called derailment or loose associations, not being able to stay on one topic. Um, Answers questions that are only semi-related or completely unrelated, also called tangential. Um, Words strung together in an incomprehensible way. We used to call that word salad. Um, and must be if you think of this as criteria here, that impairs communication. And I think part of the reason why they write that the way they do is you might look at this list here and say, well, could this be cognitive decline? Could this, be, some, representation of dementia and potentially a onset of neurocognitive disorder, or just cognitive decline outside of neurocognitive disorder? The answer is yes, it could be. So that's why we look at the totality of the criteria. But I think it's also why they say that in disorganized thinking, in this context of 5-domain schizophrenia, it clearly impairs communication. So, a person in a social situation with that individual is going to recognize that something's not right. Okay, and thinking about our cultural issues, making sure that we are not assuming disorganized speech because we don't understand that they're trying to piece together English as a second or third or fourth language, and maybe with maybe very limited exposure to English. And as I'm sure you guys know, that sometimes people who English is their second language will not say that English is their second language, and attempt to, particularly in the dynamic of a client-worker relationship and a new client-worker relationship, the client may attempt to, without saying to the worker, hey, English is not my first language, I kind of struggle with it, they'll just attempt to communicate. And so it's just something to keep in the back of your head if you're noticing disorganized speech, okay, or these speech phenomena, okay, or what appears to be that speech phenomena. Okay, so a few things that are important to note about disorganized behavior, or disorganized motor behavior. Again, it's often perceived, particularly among people outside of non-professional people, that schizophrenia people are agitation. It's exclusively agitation and aggression, when in fact that is one possible, and not necessarily even the most common manifestation of it. You see in the video what's much more common, which is almost a childlike silliness. And I think the actor in the video portrays that really well, as far as I can tell. Certainly people can move from silliness to agitation, particularly if they're, if they feel stressed or confronted, and then certainly when you have someone in the community who may be acting, what's observed to be in a bizarre manner, that childlike silliness could go to agitation based on how, the response, the first responder response. And, certainly, dovetails to conversations in our policy classes about having, separating out criminal first response to public health crises first response. So just a thought about that. Generally, these things will interfere with activities of daily living. And again, with people for first onset, it can really be just startling and very sad, because they can be very high functioning people by most standards, and suddenly they're not able to take even basic care of themselves without direct support or supervision. So, and then the other thing, catatonic behavior, again, that's often misperceived. Certainly, there are instances where it can be, where someone is frozen, or appears to be frozen in some kind of deep state where they don't move, or they're contorted into some kind of like thing like this, like a statue. But at least in my experience, that is not that's not the norm. It's generally, just someone who it's just a deep level of apathy, which gets into the negative symptoms as well. But it can be that deep frozen, not moving, even contorted into odd body, kind of frozen body movements or frozen body stances. But that's generally more just very little motor or social reaction, okay, to stimuli in their environment. Okay, so I wanted to just add another slide of catatonic behavior. Um, Again, because it is very often misunderstood and also, um, at least in my experience, seems to be dramatized in media, film, like whatnot, in ways that are really not terribly connected to, uh, real life manifestations. Um, so catatonic behavior can also be very subtle too. So, as we saw, a decreased reactivity to the environment can be seen as what's called negativism or resistance to instructions, resistance to their daily routine. Um, Suddenly not interested in going to school, um, or um, or social interactions, things that, and again, things that they maybe normally enjoy, um, and it's just suddenly an abrupt stop. Um, so rigid, inappropriate, bizarre postures, certainly, um, those can be, and they don't have to be major things. They can be, they can be sort of much more subtle, um, like arm stiffness or leg stiffness. It doesn't. It can be dramatic, but it often isn't. Um, so mutism or stupor, certainly people can lapse into complete lack of responsiveness, and for some, and can be, for an extended period of time. Again, I don't, and haven't worked exclusively in schizophrenia, but seen a good bit of it over community health and hospital, days, which were marked kind of the early years of my social work career. So I did see that stuff, um, but usually it was more subtle than that. Um, can also include excessive motor activity, and that's doesn't seem to have any purpose. So someone in the community may walk up and down, a set of city blocks. Someone just walk back and forth and back and forth. Maybe they kind of shake their head or, shake their body a little bit, like maybe walk in an odd cadence, and they'll just go back and forth, up and down the block, unending, seemingly, and certainly without any purpose. So, and that's considered catatonia as defined in the DSM. So, and then you see other things, repeated stereotype movements, again, like head shaking, staring, at people or at things, grimacing, um, unresponsiveness, verbal unresponsiveness, or just verbal echoing of speech. Um, so catatonia can represent a lot of different things. Yeah, definitely. Sometimes it can be very dramatic and overt, but many other times it can be much more subtle, at least in my experience. Okay, so negative symptoms are definitely a significant, uh, or often, sorry, not definitely, often a significant part of uh, schizophrenia, and sometimes will continue to persist despite treatment and despite being in treatment in a less acute phase of the illness, which we'll talk a little, you'll see further down the slides here. Um, so negative symptoms, again, the words of the authors here: substantial schizophrenia, less prominent in other psychotic disorders, like brief psychotic disorder. Some of the two hallmarks of negative symptoms are diminished emotional expression, and that can certainly be seen in body language, a very um, very little eye contact, looking away, really just a total, overarching reluctance to engage in any kind of human contact, including eye contact, sort of social, nonverbal reciprocity, um, speech, that's very monotone like this. When people with negative symptoms, they can't get a pitch or a cadence up and down either way. It just be flat is often the way it's described. Um, People and when they do communicate, they will generally not be expressive in their communication. Um, so they may answer your questions very softly in a very monotone uh, way, like this, um, and they're not being difficult. They're just, and they may not necessarily even be aware that they're doing it, but it's just that they're the negative symptoms, the manifestation negative symptoms, just really drive them in a very, very significant way. Or, maybe a different way to say it, as we talk about evolution here, is it's really, according to the authors, about decreased motivation. There's just no energy or interest to interface at any level with any other human being, or really anything often. So, um, and they may appear somewhat catatonic. Someone like this can be very, will sit in a chair for a long period of time. Often, people with schizophrenia tend to gravitate toward nicotine and cigarettes in particular, and they can just sit and do this for long, long periods of time and show little, and show little interest in anything else. Okay, so this is, I guess, kind of a vocabulary or terminology here. These are terms that, if you work in um, a general inpatient psychiatric or inpatient unit specializes in schizophrenia or psychotic disorders, or a community center where you work with a lot of psychotic, types of psychotic disorders and or schizophrenia. These are terms that you might hear often. Ologia is just simply diminished speech output in the context of negative symptoms. Anhedonia, decreased expression and decreased ability to um, to experience pleasure in any kind of way. So when you say, well, isn't that, wouldn't that apply to in a similar fashion to criteria for major depressive disorder? Certainly. But that's the definition. That's the term that's often used in the context of schizophrenia treatment. Asociality, again, it's the way the authors define is congruent to the way I've observed it when I've worked with folks with schizophrenia. It's not, it doesn't have any kind of, meaning the asociality. It's not purposeful antisocial, I guess, is, if that makes any sense. It's really just a total lack of interest, and there's oftentimes that can be assumed that there's kind of simmering ill will or sort of a fuse burning towards aggressive behavior, which can, but that's again, just in my experience, that's the vast minority of the circumstance, and the majority is they really just don't. Their brain doesn't manufacture, if you will, interest in social interaction, or really pleasure seeking. Any negative or positive experience seeking. So, anyway, so those are, if you hear those terms bantied about in your clinical settings, that's what they are. Okay, so a very important point here, and a concept, I think we've talked about in other parts of this course. But the authors emphasize that it's very important to rule out other um, other conditions that may involve psychosis before we get to schizophrenia. Um, and that's been my that's been my own experience too. That something that oftentimes clinicians and treatment teams are a little too quick to um, to say, hey, we think this is schizophrenia. And I think, just personal opinion, I think some of that comes from a lack of sort of forgetting of what a profound diagnosis, what we're saying to someone. Much like giving someone a diagnosis of a neurocognitive disorder, where we're saying, hey, you have this disease in which you're not going to get better. You're going to, talking about neurocognitive diseases like Alzheimer's, you have a disease and you're going to get steadily worse um, until you die. But there won't be any going back to the way it was before. And schizophrenia, while there isn't the degenerative aspect to it, schizophrenia, even without treatment, doesn't necessarily get worse per se or degenerate in the way a disease like Alzheimer's or Lewy bodies would. It does, even with treatment, typically mean that a person is not going to return to a pre-illness baseline. Um, they're not likely going to go back and complete higher education or work in an office environment, um, or uh, there are some pursuits that they won't be able to do. They won't be able to return to, and independent living even independent living may be is often out of reach for people with schizophrenia. So I think we have to be very careful, and make sure we've really done thorough ruling out before we, the term schizophrenia passes through our lips to a client or a client and a client's family and or a client's family. So just a thought on that. The other thing, just a touch on schizotypical schizotypal personality disorder, defined as a pervasive pattern of social interpersonal deficits. So a lot of the negative symptoms, some of the hallucination and delusion aspects um, that are chronic but um, don't necessarily represent a significant functioning limitation of overall functioning. So, and I think it's not a diagnosis I've necessarily seen a lot of. I think there's a lot of, as is the case with personality disorders in general, I think there are often a lot of other factors related to a client that are not fully explored before we assign personality disorders. But that's a conversation for another lecture. But that's just the that's the basic framework of schizotypal personality disorder as defined by the DSM. Okay, so the nice thing about these preface sections in the DSM for each of the major sections is it also gives a chance to kind of hit some summary points from the entire section. Uh, whatever section we're looking at in the DSM. So some highlights from the preface section. Um, we just talked about the rule out aspects of schizophrenia as as guidance. It's given by guidance by DSM authors. Delusional disorder, which we won't get into deeply in this lecture just for time, um, is characterized by 1 month of delusions but no other psychotic symptoms, which is a good summary of delusional disorder. Brief psychotic disorder, by contrast, is lasts more than a day but remits in a month even without treatment. And often brief psychotic disorder like delirium can have a cause of non-behavioral health and non-mental illness cause, such as a serious infection. So what's the difference between that and delirium? Well, may not be a whole lot, except some of the deeper nuances of the criteria. But brief psychotic disorder is short term and will resolve itself. Doesn't mean it won't come back necessarily, but won't persist beyond a month as defined by the DSM. Here's another big one that I often see people, too quick to go to schizophrenia. They don't respect the 6-month guidance, and just what I've seen over the years. But and we'll get a little bit more. We'll get into a little bit more of the active phase. I've got that, and more defined further in some of the subsequent slides forthcoming. But this 6 months symptoms for persistent symptoms for 6 months before we start talking schizophrenia with somebody. It doesn't mean we don't start applying treatment. We don't call us back in 6 months. You're still delusional or anything like that. It's just in terms of diagnosis and maybe even. I think, we could talk about putting things in our notes that we don't necessarily code, at least at that time. Again, schizophrenia, people hear schizophrenia and it can be like hearing the words cancer. You better be sure of what you're talking about before you breathe those words, cancer or schizophrenia, to a client or patient, because that's a heavy impact on an individual, understandably. Okay. Schizoaffective disorder is sort of some of the schizophrenia symptoms with also mood symptoms. So what they call mood episodes, which mood episodes can include manic or hypomanic as well as depressive. So think of mood episodes in the same way it's defined in bipolar, followed by active phase symptoms of schizophrenia that occur together. Followed by 2 weeks of delusions. I said, wow, that's pretty complicated. Yeah, it's a little bit complicated. But if you're, if it's like, well, it seems like schizophrenia sometimes, it seems like bipolar sometimes, or sometimes it just seems like chronic severe depression. If you find yourself thinking that, or you hear other clinicians saying that, that's a good time to take a closer look at schizoaffective disorder, just as a my own thought about it. Okay. So I just included this in here since it was mentioned in there that schizophrenia may not be a distinctive illness in future DSMs. Don't get too hung up on that now. I know schizoaffective disorder is a diagnosis that is used relatively often. So don't oh my God, you mean it's not real and it's going away? Who knows? We'll see. I just called it out there because the authors called it out, and I said, whoa, I didn't know that. So I wanted to make sure that I highlighted it since it was something that I was a little surprised to read too. Just as I was saying before, psychotic disorders can be brought on by substance intoxication. Sometimes psychotic symptoms can persist after cessation of the substance, but the effects may still linger. Certainly we see that in hallucinogens, as we've talked about. Things like serious infections or other conditions like depression. Some people will have hallucinations or delusions. It's not common, but it can happen in the context of depression. Okay? And certainly can happen in the context of a manic or hypomanic episode as well. So lots of things to consider before we get to schizophrenia. Okay. Okay, so here's where we plug in our 5 domains into the criteria for schizophrenia. All right, so and again, these are these will make these things can make handy multiple choice questions. But you don't necessarily need to memorize them forever. This is why I encourage you to keep a DSM handy, and don't feel bashful about referring back to it often, as I do. Okay. So criteria A for schizophrenia: 2 or more of the 5 domains of schizophrenia, and each present for a significant portion of time during a 1-month period. Okay, so 2 or more of these happening all or most of the time in a 1-month period, and at least one of those two must be from the first three, which are considered the more, you'll hear the active or acute phase of schizophrenia, and this more the recessive phase of schizophrenia, meaning 4 and 5. So, okay, so does that make sense? You have to, you got, and it can, by the way, it can be any combination. This is just sort of the minimum for, as by way of guidance, criteria guidance. This is the minimum. You can see all of these, and you can see any combination. If you only see 4 and 5, what they're inferring is that you might be looking at something else besides schizophrenia, if you're only seeing 4 and 5, okay? If you're only seeing 1 through 3, you might still be seeing schizophrenia, but only in a active phase without a recessive phase, okay? Okay, so criteria B, in my opinion, is maybe obvious, but very, very important. If it's schizophrenia, their life is affected. There is no schizophrenia light. If someone has schizophrenia, they're not holding down a complex job. They're not pursuing higher education. I don't mean in a pejorative way. I mean, it just doesn't happen. And if people are able to function in that way, it's not schizophrenia, at least in my experience. And that's, congruent with what the DSM authors find. Okay, so it's really a profound impact, and it's a lasting profound impact. And people can be treated and it can be minimized, but it's a lasting. And this is why it's so important that we work the book and we really stay disciplined about rule outs before we start, and the 6-month period before we start talking schizophrenia to a client's family. Okay. When the onset is in child or adolescence, there's a failure to achieve expected interpersonal, academic, occupational functioning. I will tell you that not only is childhood, and when we say adolescent onset, 18, maybe even 17 is not necessarily that uncommon, but earlier adolescence or childhood, all I've seen is it diagnosed when it's really something else, usually severe trauma. That's been my experience. Just my experience, my own personal experience. So you take that for what you will. You hear other people tell you different, ponder it, consider the source, draw your own conclusion. That's what I've seen. When the schizophrenia diagnosis has been assigned to a child or young adolescent, what I find is that the book hasn't been followed. People haven't done the work by the numbers, and often what they're missing is severe trauma, and acting out from severe trauma. Just my 2 cents on that. Okay, I was using the word recessive before. The word, meaning for when schizophrenia is exclusively in the 4th and 5th domains. The word the DSM uses residual. Okay, so those are only negative symptoms. But criteria C is essentially what we just talked about with the 6 months. Again, very obvious, simple to understand, but very, very important, and I think not always honored, just in my own experience. Okay, so really important also that one of those months you must see the 1, 2, or 3 in criteria A, the active phase symptoms. Okay, it can include the residual symptoms from the 4 and 5 domain, but you've got to see at least one of the 1, 2, or 3 for 1 month if you're going to call it schizophrenia, according to the authors. Okay. Okay, so in criteria D, we see a little bit more focus on the we'll come back to the rule out aspect. Okay, particularly depressive disorder or bipolar disorder, that those have been ruled out. Some additional guidance are that that when you're seeing active phase, that there's not other evidence by criteria, symptoms and by observable criteria, observable or reportable, that you don't see. What you're not seeing is in the context of a depressive episode or a manic episode. Okay, and certainly, particularly in the manic episode, when we talk about domains 1, 2, or 3, there can be some overlap. So, and so what they say is look for mood symptoms. So go back to that criteria for mania, hypomania, and depressive disorder from the bipolar section. Again, doing the discipline of working through these things before you get to schizophrenia being sort of from the diagnostic standpoint, one of the last train stops you want to come to. You want to, again, like something like Alzheimer's, you want to try and rule out as much else as you can before you get to that diagnosis. If mood episodes have occurred during active phase symptoms, they have been present for a minority of the time. So it's a little bit, so they're saying you could have mood episodes, but they should be present for the minority of the time. So they're, you say, well, is that a little bit of a backpedal of what they said here? Maybe. My guidance is when you're seeing that 1, 2, or 3 stuff, and some of this will be by history too, or, you're going to need report from other people because, the client themselves may not be able to, report clearly on what's going on, and, maybe scared and not necessarily wanting to, be open about what's going on, nor may they be able, they may not be able to as well. So, but really explore the criteria from bipolar, not so much the bipolar 1 and 2 criteria, but the criteria for the definitions of manic, hypomanic, and depressive. And when you're in your LMSW phase, I strongly encourage you to. These are complex diagnostics we're talking about, and look, I mean, the giving someone the diagnosis of schizophrenia, has a little bit of a different weight than maybe the diagnosis of depression, let's say, or adjustment disorder, for instance. Okay, so please don't hesitate to really try to process this stuff with a supervisor when you're in LMSW phase, and and working as an independent, private practice, and you think someone may have schizophrenia, or you have family, you have a family bringing, a 18-year-old in, or maybe even a 25-year-old in, saying, I'm worried because here's what I'm seeing, and you think you may have schizophrenia. It would, before you get to the diagnosis of schizophrenia, it would be good to get some support on that. Psychiatrist, if you can, that would be a good time to really try, if you can get a psychiatrist, to get a second, opinion from a psychiatrist's point of view, or even another LCSWC before you get there. So and again, you don't necessarily have to do that, but it's just the way I would approach it in private practice. Okay, so criteria E reminds us to rule out substance. Okay, substance intoxication, particularly when we're talking about hallucinogens, but even heavy use of other substances, including alcohol and marijuana, can produce delusions and paranoia, and even hallucinations if used heavy enough and long enough. So consider all those things, and before you get to a diagnosis of schizophrenia. If they're using, I guess I'll go back to what I maintain, personally, is that if you have heavy regular use, you really have to address that before you can get to a firm diagnosis of something else, and particularly when we're talking about schizophrenia. Okay, it doesn't mean you don't offer treatment. Don't offer a medication evaluation, or try to get them to a medication evaluation, because if they do have schizophrenia or some other, or bipolar, or even depression, and we get them started on some treatment for that, then that may help with the motivation to recede the substance use. But really, if you got the substance use, you got to deal with that first, and it's hard to really definitively say some other diagnosis, particularly when we're talking about schizophrenia, when you've got daily heavy substance use, really of any substance. The authors also call out autism and communication disorders. Uh, Autism in particular can often be confused with schizophrenia and its adult manifestation. So they offer some additional, um, people with autism often can have, some of the negative symptoms that we talk about uh, can be found in autism, particularly people on the more severe end of the spectrum. That reluctance, that lack of, sort of a lack of motivation and uncomfortableness with social interaction. Um, so, uh, so what they say is that the diagnosis of schizophrenia should only be made if prominent delusion or hallucinations, in addition to the other required symptoms, are present for 1 month. So they say persistent hallucinations, illusions. I think where they're going with that is making sure that people don't confuse domain 4, the negative symptoms, with autism spectrum disorder, particularly if you're aware of that by their history. Okay, just a few words about brief psychotic disorder. This can actually be an important diagnosis to know. Places where this diagnosis might come up for you is if you're hospital social worker, working in quote unquote general medical. A lot of times they'll have patients who come in and have these kind of symptoms, and it can be assumed that they must have schizophrenia or a psychotic-based illness, um, or related to substance intoxication, and that can be problematic because it can cause the medical team to not run some basic test that may indicate uh, another cause for the psychotic symptoms. Uh, Perhaps probably the most common of these, or at least in my own experience, is the phenomenon of infection. Urinary tract infection can be a very common one, where because of the infection, suddenly you see some of these psychotic symptoms here with a person who either has no psychiatric history that we're aware of, uh, does not appear to be within the context of substance intoxication, or that they do have a history of mental health issues, or a mental health illness, or or substance use disorder, but this is a marked departure from their baseline state or their history of symptoms. And to that end, this can be equally applicable working in any kind of outpatient community health setting where you have someone who does not necessarily have a history of psychosis, but suddenly they are very psychotic. And to further that, you may have someone with a mood disorder that has a history of psychotic symptoms, or someone who does have a psychotic disorder, but you notice these symptoms, and they're in the context of brief psychotic disorder. They're generally very unmistakable, and an abrupt change from where they are, even if they do have a psychiatric history. So, um, so when you see that, uh, when at all possible, to get some basic lab work done on a person. The other thing that can happen are brain tumors. So sometimes these symptoms can come up in the context of someone who has a undetected brain tumor, be it cancerous or non-cancerous. Any kind of mass on the brain could potentially bring about these systems. So brief psychotic disorder is when these psychotic symptoms are one, come on very quickly. They last at least a day, but less than a month, and are not attributable to something else. And we'll say a few more words about this in the coming slides. Now, just to add a word here about eventual full return to premorbid level of function. That so I think the way, at least my interpretation of the way the DSM reads, is that it infers that this will happen on its own, which it can. Um, but perhaps what's really more often applicable is a person will have a full recovery, full previous level, what they call premorbid level of functioning, with the proper with proper medical health intervention. So, in other words, if someone is this is a result of an infection, that infection has to be treated for the symptoms to recede. The good news is, and again, this is not from the DSM, but just from my own experience, when people are experiencing these combination of these symptoms from an infection, uh, their these symptoms recede really, really quickly once an antibiotic has been started. So anyway, so I just wanted to, but without medical treatment, I don't know that necessarily that they folks, depending on what the etiology is of these psychotic symptoms, it may not necessarily refer to full functioning without proper intervention. Now, again, what you may find is if the person does have a history of either mood disorder with psychotic symptoms or psychotic disorder, this can be a challenge to figure out if it's a brief psychotic disorder or it's psychotic symptoms related to their chronic condition, um, such the same as use of some substances. So, uh, misuse of hallucinogens, and particularly, but not limited to, can certainly bring about these psychotic symptoms. Potentially severe withdrawal can as well, such as withdrawal from alcohol or benzodiazepines. So there's lots of, it can be complicated to tease all this out. And certainly if you're working on your own in a practice, and you see this abrupt mental status change, you probably want to get some additional support, medical support. Now, DSM reminds us that it does not necessarily have to be a physiological etiology for brief psychotic disorder. This can be in reaction to a stressor, or at least a stressor in combination with another medical health issue. And So certainly, if something, a severe reaction, such as an automobile accident where um, perhaps the person survived, but they lost loved ones in that car accident, as a for instance. Um, you might see a brief psychotic disorder in reaction to that tremendous grief, and you would have to look at the acute stress disorder criteria carefully to tease that out. And it can be a little bit complicated, but diagnosis notwithstanding, obviously this is going to be a person who needs immediate intervention, and could be potentially vulnerable in their setting without intervention, regardless of whether it's a physiological etiology or a traumatic response or response to a traumatic event. I'll tell you, when I've seen brief psychotic disorder, um, it is. I've never seen what I would consider to be a mild brief psychotic disorder. It's always pretty severe. Functioning is significantly impaired. The person may be incredibly vulnerable um, in their setting. So, uh, just a note about that. They can definitely, one of the things that can happen is you can have an awareness that they are in some sort of state of confusion, which ratchets up their distress. So they know there's sort of the blunt way of putting it. They know they're not right, and that can be incredibly terrifying for a person. Um, so it is often, um, you know, non-psychotic to clearly psychotic state is definitely consistent with my experience.